join us and give us a talk on childhood asthma. Dr. Ghulam Mujtaba is a consultant in Pediatric and Respiratory Medicine at Manchester Children's Hospital, and his specialist interest is including cystic fibrosis, asthma, and respiratory infections, and expertise in particularly interstitial lung disease. He has worked in various prestigious institutions like Great Ormond Street, and he's currently lead in Pediatric Respiratory Medicine, and also jointly a lead in cystic fibrosis. He's an honorary lecturer in University of Manchester, and currently acting as academic advisor for medical students. So without any delay, I will ask our guest speaker, Dr. Ghulam Mujtaba, to tell us more about the childhood asthma for ordinary people. Thank you.
Thank you, Dr. Tariq, for an extensive introduction. And first of all, thank you very much for actually giving me this opportunity to talk about children asthma and share my knowledge and experience. And thanks to the 3MEM Foundation as well. So as you have mentioned, I work in Royal Manchester Children's Hospital. My area is children's lungs, and asthma is one of those. So I have no conflict of interest to declare for this presentation. My time is well and true. Objective of today's talk is we'll go through what asthma actually is, how we diagnose asthma in children in particular. My focus is going to be in children. And my talk is, I've tried to keep it very simple and understandable for everyone. What are the triggers for asthma? We'll go through what happens if a child gets an asthma attack, how to recognize it, and where to go for help and how to treat it. What are the treatment and treatments for options for asthma and how to prevent it, and some frequently asked questions and myths, and obviously I can answer any questions at the end, or if people have specific questions can put in the chat box, and I'm sure Dr. Tariq can direct me to those. So what asthma is, it's a long-term condition and affects our airways. And these are the tubes that carry air in and out of, our lungs. So these asthma may cause wheezing. I'll go through in a minute what exactly wheezing is, breathlessness, chest tightness, and a dry cough, particularly at nighttime. Early morning can happen during the day or exercise as well. Wheezing, I must say, is important to understand. It's a whistling sound, which children, when they are, or even adults, when they have the asthma symptoms, the whistling sound comes as you breathe. This can sometimes be difficult because children having common colds, cough, having some secretions can present with certain noises from the chest, which can mimic like wheezing. So wheezing can be difficult. But once you've seen it and been seen by your GP or seen by a specialist who have kind of explained what this is, then it's easy to recognize. An easy way to, if you're not sure if your child is having those symptoms, is to actually record it and show it to your doctor that what you mean by wheezing. These episodes are usually associated with, they're widespread, but variable. What happens, there is airflow obstruction to the lungs. And it's most of the time reversible, either spontaneously initially or if asthma symptoms are persistent, then you need treatment and they're reversible with treatment. Asthma prevalence, asthma worldwide in 2019, according to WHO, there are 262 million people who have asthma. In UK, there are about 5.4 million receiving treatment as of data a couple of years ago. And there is about 1 in 12 adults, 4.3 million adults having asthma. And in children, it's about 1.1 million, that is 1 in 11. So in a class of 30 to 40 children, you would have on average 3 children who are diagnosed with asthma. It's more common in boys in children, while in adults, it's more common in women. Some of the factors we understand and know, like hormones, but others we don't understand very well why this happens. This is the data from United States, and what you can see here, that in children, as I mentioned, that asthma is more common in boys as compared in adults. It's more common in females, and the trend changes as you go over towards adulthood. Some facts about asthma in UK. Unfortunately, 3 people die from asthma attack every day in United Kingdom. There are about 200,000 people who have severe asthma. NHS spends a lot of money on asthma, about 1 billion a year, treating and caring for people with asthma. In 2016-17, the last data I have available, there were 77,000 admissions to the hospital with asthma. And unfortunately, in 2017, 1,484 people died from an asthma attack in the UK. And still to this day and age, despite advances in treatment, smaller number of children still die of asthma. Some other figures and data, as you can see here, emergency admission, hospital admission for asthma in 2016 to 17. And here in Northwest, where I am currently, this area, unfortunately, the number of hospital admissions are higher. We are trying to understand, and some of the factors might be related with socioeconomic factors, some with ethnic and genetic predisposition to asthma, but some of the factors are still not understood. And we think maybe the way the data is collected might be contributing to some of this, but we are not shying away from the fact that the asthma admission rates in Northwest are higher than rest of the country. Here you can see from Asthma UK data, again, from 2014 to 2016, looking at emergency asthma admissions. Overall, I think the positive news is that we have learned, we have got things better, and the emergency asthma admissions numbers are going down. But what you can see on the top, the bulk of these admissions are still children. So it's really, really important that we keep improving this and getting this right. And what you can see here, and most of you would know that the asthma exacerbations are worse in winter. So here you can see year on that the months of emergency asthma admissions go down in summer months, but as the winter hits, those numbers go up and then gradually settle down. So there is seasonal variation to asthma, and that is proven that particularly in children, with the viral infections, they add on to exacerbations of asthma, which I will come to in a minute, looking at what are the triggers. So What actually happens, we call pathology in medicine, but actually what happens in asthma. So asthma involves inflammation of the airways. So if you look here, when we breathe in through our normal airways, the function of the lungs is to take oxygen and air to the heart, to the blood vessels, and then they carry on this oxygen which we need for our body to function. In asthma, these airways are basically inflamed. And if you can see my pointer, this is what, a diagrammatic representation of asthma, where the airway, as you can see, have these smooth muscles. And these muscles become very tight. And this is a normal airway. This is an airway with a person with asthma, where you can see that this airway is tight. And when this airway is tight, and if you can imagine, this lumen here is become much smaller. And if there is with inflammation, particularly long-term or chronic inflammation, there is mucus production inside, and the airway is blocked. And that's what, when I was saying, it leads to wheezing, chest tightness, and you find, and the children find difficult to breathe. So when we talk about the risk factors for developing asthma, one of them is family history. So when we go through the history with the children and their carers, we look at family history, because that's important. Although every so often we meet children in our outpatients where there is no family history, but it predisposes. If you already have a family member, immediate family member with some sort of what we call it atopic conditions, so like asthma, eczema, hay fever, or allergies. And we often see that one family member might have eczema, another one might have hay fever, and a different family member might have a allergies or asthma. So there's a bit of crossover between these conditions within a family. And then obviously environmental exposures, which I will talk about. Atopy, as I said, what atopy is, it's body's predisposition to develop an antibody called immunoglobulin E in response to exposure to the environmental allergens. And why this is important, because some of the treatments are specifically targeted against IgE. This can be measured in the blood, and the atopy includes things like allergic rhinitis, which is basically due to allergy, you have persistent nasal symptoms or symptoms related with the nose, like runny nose, itchy nose, rhinorrhea, asthma, hay fever, and eczema are the other atopic conditions. Eczema is dryness of the skin, which can vary from mild, moderate to severe, generally more common in children, but some children continue to have eczema symptoms and unfortunately can have quite severe symptoms as well. Here, what you can see a picture from Lahore in Pakistan a couple of years ago, and this picture is actually before the COVID, and you can see some children obviously wearing masks at the time as well. This picture is from 2017, and you can imagine the smoke in the background in terms of the air pollution. And the children, as I showed you the picture earlier on, our lungs are actually exposed to the external environment. So whatever wherever you are inhaling that into your lungs directly. And then that leads to cascade of inflammation. And that, if you're already predisposed with the other factors, then you will develop asthma. Other things like pollen is common, particularly in UK, in certain season, as we looked earlier as well. in pollen season, children become more symptomatic. And again, all of these risk factors which I've mentioned vary from child to child. Some children, despite our extensive review, history, and looking at some blood tests, we cannot find the exact trigger. Pets, again, can be a risk factor leading to exacerbation or trigger. House dust mite, and fungus and mold, and respiratory viruses, particularly in younger children. They present with what we call viral induced wheeze. So they may not have a diagnosis of asthma as such, but the respiratory viruses trigger the asthma symptoms. And once these become recurrent, then usually leads to diagnosis of asthma. Environmental tobacco smoke, obviously, and in particular for preschool age children, when their lungs are developing, I think that's really important that, children's lungs, the little tubes are made before they're born, but they continue to develop and divide for many, many years. And this is really important. And that time of development, the tobacco smoke exposure really causes inflammation and can lead to asthma. Other things like fragrances, some children may be predisposed to develop asthma symptom, but the evidence is low. Reducing exposure to house dust mite, as I mentioned earlier, is one of the risks, and how you reduce it is there's a long list of things. And I think it's really important that, I don't want people at the end of this talk going and, starting hoovering and, doing all the extensive stuff, but common sense. And again, we can test for host dust mite. We can test with the blood test. And if you feel that this is the trigger for your asthma, for your child's asthma, then you can, go through these things, which will help. As I mentioned, from the tobacco smoke point of view, evidence suggests association between environmental tobacco smoke exposure and exacerbations of asthma among school-age children and in adults as well. And again, in preschool children as well. Just a diagrammatic representation here. You can see what you breathe. Really, on one hand, a lung, basically with the, all the inflammation. In terms of pets, when parents come to me and if they already have pets and child has asthma symptoms, I usually ask them to only test for it if you're ready to remove the pet, because it's really very difficult, and some children are quite attached with the pets already, and then can be difficult, and then you have to balance on that. But certainly some children can be at high risk with trigger from pets. There is evidence that the elimination of mold and the mice conditions, they permit mold growth and prevent asthma exacerbations. And the other things which like grass, tree, weed, pollen. Now, it's really important that, we cannot live in a glass. So all these factors can exacerbate. For some children, unfortunately, it's more than others, things like pollen and grass. But, children have to enjoy the life, and it's important that they do exercise. So we encourage parents to continue their, daily life, be in school, other activities, and control the symptoms. And I will go through the treatment, and we can actually improve the quality of life with treatment. So it's all the balance. You don't want your child to miss from their day-to-day activities. So coming back to the symptoms of asthma, if your child is having dry, persistent cough, so in UK weather, in particularly in winter, it's not uncommon for children to have common colds, cough. If it's for a couple of days, usually settles down, starts with a low-grade fever. These are usually exacerbated by viruses, but I'm talking more about a dry cough, which is persistent for many weeks, usually worse at night, and they become short of breath. And when you ask them, when you're looking at them as compared to their peers, they become more breathless, and if they're playing sport, they have to stop more than other children. And the family history, as I already mentioned. Another risk factor is prematurity. And I'm talking about extreme prematurity, usually, like children who are, let's say, less than 32 weeker, who needed some sort of support when they were around the time of birth from lungs point of view. Most of the extreme premature, like under 28 weeks, majority of them have some symptoms related with wheezing and asthma, and they need some sort of treatment down the line. And when we go through history, usually if there is eczema, hay fever, and other allergies, that makes us think of asthma as well in these children. On examination, if the child is actually having these intermittent symptoms and they are otherwise well and have not had any asthma attack, and if they come to clinic, for example, to a GP, they might look actually completely well, and you examine them, you rarely find anything of note. But we look for subtle things, like if they have some dry eczema marks or some chest findings, which can kind of suggest that there may be element of asthma. For example, with the they might have wheeze when we listen to them, and there is difference how a child presents acutely versus a chronic. And when I say acute, is like if a child has an asthma attack. Now, with the overall awareness in public, it's kind of rare that you develop an asthma attack as a first presentation of asthma, but it has happened. And unfortunately, I've had children who came into hospital for admission and then even needed intensive care. I mean, I'm talking about smaller numbers, but sometimes they presented into hospital and they needed intensive care with their very first presentation of asthma. So in acute condition, if it's kind of very first time, or even if a child who's known to asthma, acutely they can be quite unwell. You would see them difficult to finish the sentences, and short of breath, and children tend to just lie down, and then they may say, slightly older children may say they're finding hard to breathe. So these are the usual symptoms that they find difficult to kind of run around, and the dry, persistent cough, and and if they lie down, it just kind of gets worse. And if they kind of sit up, it helps them. So these are the kind of symptoms and signs we look for, and as a parent, you can look for. So in terms of asthma, obviously, if you're going to your GP, they will go through the history. They will examine you, they will look at the history, and they would, if there is a family history and there is other triggers which you have described, then they might give you a diagnosis of asthma, and you may not need to see a specialist, and they would start you on some treatment, which is reliever and preventers. The relievers kind of immediately relieve your symptom of asthma, while the preventer are kind of more longer term, which I will go through in a minute. But when these children come to us, they are probably gone through the GP already. Some of them are even gone through a general pediatrician. So we have a kind of a system in our clinic where we do lung functions. So children kind of breathe through, and we have a kind of on a laptop, we can see the obstruction, airflow obstruction, and through a mouthpiece, our physiologist is there, and they kind of help them. You need about children of about 5 to 6 years. Younger children, it's hard for them to coordinate for this test, and you need a trained physiologist to do them. Now, we have increasingly now with the technology, we have even smaller and smaller, we call them spirometers, which can check for airflow obstruction, and we even have very portable ones. But again, important thing in children is the technique, making sure that we have the right technique. And what we are looking for in the spirometry is to see whether they have any airflow limitation or obstruction. And we can also do something called reversibility, where actually children first get the spirometry, and if their lung volumes are low, we call it FEV1. If it is low, then we give them salbutamol, which is a common reliever medicine, and see whether their airway actually opens up. And we call this bronchodilator reversibility. So that kind of straight away tells us that this child is actually responsive to the treatment, and makes it much easier for us to diagnose. The other things here is we call it exhaled nitric oxide. Again, quite a simple test. As you can see, a very small machine. We attach a little, this is our own machine in the hospital. It's a little filter here, which goes in here, and the child breathes in and out nicely, and we get a result straight away on exhaled nitric oxide. Now, none of the tests in asthma is gold standard. So what is gold standard is combining everything. So you have a history, you have the examination, you have these tests which actually help us. Now, blood tests, there are certain allergies and IgE level. If IgE level is held, it supports diagnosis that's more an atopic. And then we look for specific things. We ask parents, and if there's triggers like pollen, we can check. We can check for tree, grass. We can check for dust commonly. And these are the kind of blood tests can be done, or skin prick testing can be done as well. Now, chest X-ray I put in there, but is really helpful in diagnosis of asthma. Now, when they come to us, obviously as a tertiary center, a lot of these children have already gone through some initial treatment. So we do a chest X-ray just to make sure that we are not missing anything else. But in asthma, vast majority of the time, the chest X-ray itself is normal, because the little tubes which you see, which have inflammation, cannot be seen on chest X-ray. However, if a child has a severe asthma, later down the line, they can have some changes on the chest X-ray. I would not go into too much detail of that. And very, very rarely we in hospital do what we call flexible bronchoscopy. We look down the airways with the camera. Now, this is probably 5 to 10% of the children which are referred to us. We do that. Children are usually asleep. In adults, you can do it awake. In children, we do this when they're asleep under general anesthetic in our theater. And what we look for is how much inflammation is there. And we also make sure if children are already on a reasonable amount of treatment and their asthma is not getting better and they're still having lots of what we call exacerbations or asthma attacks, we want to make sure, again, we are not missing anything else before we continue to increase the treatment, because obviously the treatment burden as well as the side effects of the treatment. So during this process, sometimes we do bronchoscopy, and this is how the airway tubes, the trachea, looks in a normal healthy child. And again, in asthma, it could actually look exactly the same, or sometimes we notice some inflammation, but what we are interested is to find out something else. For example, in this child, what you can see here as well is this trachea is quite floppy. It's a completely different condition and actually relatively common. We increasingly are actually finding these children who are on asthma treatment have what we call tracheomalacia, that the airway is actually floppy. So it's important that if your child is on asthma treatment for a while, either through the GP or pediatrician, and child is not responding, that then can be referred for tertiary respiratory review. So coming back to treatment for asthma, so you have the reliever, which is the most common one we use here in UK and worldwide, is the it's called beta-2 agonist or salbutamol. You might have heard the name Salamol, or as a trade name, or Ventoline, but salbutamol is the medication. To start with, I think that's the first medication. Most of the children which come to us either through the GP or pediatrician, children are already on salbutamol. So salbutamol is important medication, part of the asthma treatment. What it does is relaxes that smooth muscle, which I showed you earlier on. So the airway, because it's a reversible condition. So once you use the salbutamol, the muscle, smooth muscle relaxes, the airway opens up, and the child then feels better. The cough settles, because cough is a natural phenomena trying to actually help the child when the airway is narrow. Then we come to preventers, which the mainstay of preventer treatment is the inhaled steroids. So they are regular, and that's the kind of important message that, inhaled steroids or the preventers are not just to use on the day when you have symptoms. They should be used every day until your GP or your pediatrician or advises you to stop them. And what we do is, once you're on the inhaled or preventer treatment, we review your asthma regularly, either in hospital or by GP or even by asthma nurses, and they go through your symptoms. And if things have improved and there is a period that you've not had any asthma symptoms or exacerbations, you've not had any hospital admission, or oral steroids. Now, oral steroids we try to avoid wherever possible, because oral steroids are fantastic for reducing the inflammation, but and they are mainstay of asthma treatment, and we use them all the time. They're as I said, they're really good medication, but the goal of asthma treatment is that you have such a fantastic control of asthma on your inhaled steroids that you don't need to go to the hospital. You don't need to use the oral steroid. But despite doing that, if you still need it and your doctor advises, that's absolutely fine. I mean, there are side effects. We can measure those as well. And occasional steroid use in children is not dangerous. In terms of other medications like montelukast, we use it in younger children as well. There is evidence in children who have what we call viral induced wheeze. That's kind of a pre-asthma, and you know, when we are not sure whether these children are eventually going to have asthma, particularly young, like 1 to 2 year, 3-year-old preschool children, if they are having lots and lots of wheezy episodes with viruses, we try Montelukast as a preventer, and it does work for lots of children. And then obviously children with asthma who are already on inhaled steroid, may need add-on treatment with Montelukast. Now, Montelukast, I must say, there is a smaller proportion of children who develop kind of nightmares or other side effect with it. We usually say to the parents at the start, and if that happens, it's again reversible, and we just ask parents to stop it, and that settles down. It does not have any long-term side effect, but just one of those. And those children who have this side effect, unfortunately, cannot have this later on. The other medications like theophylline, again, they are down the line. By that stage, we would have looked at other, ruling out other conditions, ensuring that technique is good, the compliance is good, the child is actually taking the medications and using it properly and taking it every day. And obviously, in slightly older children where parents are actually not supervising and leaving it to the teenagers to take their inhalers, and in a busy world, if I have to take an antibiotic for 7 days, I must say, I admit that I don't take it regularly for 7 days, even twice a day or 3 times a day. Sometimes I miss or I take it slightly later. So we have to accept that we have other things in life. So it's really important, and being honest with your physician and explaining that, because there's no point if on your letter I see that a child has already been on inhaled steroids and Montelukast, and you say, oh yes, the child has been taking it regularly, then I will be looking at either this is not asthma. If it is asthma, then I have to escalate the treatment. So before escalating, it's really important that you discuss. And what we say is, if you feel that you've not been taking it regularly, maybe try it for 3 months or 6 weeks, take it regularly and avoid the triggers, and your asthma symptoms may improve. So we rarely escalate the treatment to next level before going through the basics. So basics are really important. And biologics, there are 2 of those which are used, but again, in a very small proportion of children with the very severe asthma. That involves usually, initially, particularly hospital attendance twice a month. So it's quite troublesome from that point of view, going to the hospital. But for those smaller proportion of children who have severe disease, they are useful. If your medicines are working what you should expect, and what we are actually aiming from treatment of asthma, what we're aiming is no symptoms during the day, your sleep is, and your child's sleep is better, not waking up at night, and less need for the blue inhaler or the salbutamol or reliever inhaler. So, the children who are well controlled, they then come to us and say, hardly remember when that was last time I've used the salbutamol. So that's really important to remember. And not having any asthma attacks, not requiring to go to hospital, good lung function, and to be able to get on with daily life, including exercise, without asthma symptoms getting in the way. So preventer inhalers, Asthma UK is I would suggest anyone who's looking for any information, either healthcare professionals or our parents, can actually look at Asthma UK website. It's really useful and actually goes through the inhaler techniques in various ages, including children and adults. And the and this slide, as you can see from Asthma UK, using your preventer inhaler, it reduces the inflammation, protection from the trigger, and you have fewer symptoms. So you have to take these preventer inhalers every day to get this outcome. And as I mentioned, the Asthma UK, they have the different sort of what you're looking here is spacer devices, which you use for your inhaler. And it's important to talk to your asthma nurse or pharmacist. They can explain to you. You can look at the video, making sure that you're taking it right. And usually we either show the parents in our clinic, and I have some of the inhalers. If we have time, we can go through, but we usually show them how to use the inhalers in clinic. We have asthma nurses. If we feel that the asthma control is not good, they go through this as well. And you know, in younger children, as you can see here from Asthma UK, they're showing this child sitting nicely in mom's lap. You have a what we call an aero chamber. The inhaler is attached here at this end, nicely fitting face mask. So it's really, really important that there is no leak around that, and you have the right size face mask, because these vary, like, you know, there are for younger children like under 2 and then 2 to 5, there is one with the bigger face mask, and then older children like more than 5, they can have a mouthpiece device, so they don't necessarily need the face mask, so we change them to a mouthpiece device. So they come in different shapes and kind of, I suppose, specific age groups. So it's really important that they are using the right device with the inhaler. And it's important, here you can see a child using another what we call a spacer device, which you know, slightly bulky, but again works well. There's usually a little valve which you can hear like clicking as the child is breathing in and out. And here you have a you know, a preventer inhaler attached. So what I wanted to mention here is that there is a myth that you become dependent on inhalers, and that's not really true. You know, I think if you don't use your preventer inhaler, you will end up relying more on the salbutamol, using it more and more, and your inflammation, like as you can imagine, your smooth muscle will relax, but there would not be long-term reduction in inflammation. So you would continue to have asthma attacks, your quality of life will be poor. So that's not true. And the other important thing is when you're taking the inhaler, you're taking the medication directly into the lungs. So systemic side effects, you know, it's not, the absorption to the other parts of the body is minimal. So you're targeting the medication directly to the lungs. Another kind of myth is that, you know, oral medications, and I see, unfortunately, because, you know, whenever I visit Pakistan, and a lot of family members and other friends sometimes take advice, and it's commonly used like oral salbutamol over there in the syrup form or tablet form. But here in UK, I hardly ever seen, like, you know, it's not in the practice or guideline. We just use inhaled salbutamol, and it works fantastic. So there's no need for oral, because that's oral syrups then actually you know, increase your heart rate much more and cause other side effects as well. So oral medicines are not better than the inhalers from asthma point of view. This one I wanted to mention, when we see children in clinic, and you can actually download this from Asthma UK, anyone can download, whether you're a healthcare professional or you're a parent, and we give this to our patients. And here you can see, we mention what triggers this child has, when was the last clinic, and the this asthma action plan, kind of asthma plan, goes through what preventer you're on, and the what preventer medications you are, and if day to day, if you have a bit of cough, what do? You use 2 puffs of salbutamol, for example. Give you an example for this child. And if your asthma is getting worse in a orange zone, what to do? And you can use slightly higher doses, and how often, and when to get worried. And then obviously if you're having an asthma attack, then what you do. So this is really useful, and we usually nowadays with technology, you can just take a picture, share it with your family, everyone has it, or you can attach it in the kitchen, your asthma action plan, so that everyone knows if having symptoms, what to do. And I get this asked commonly in the clinic, from parents that, should I limit my child from exercise? And, my answer is obvious. No, we need to actually improve the asthma control so that the child is able to do whatever they enjoy, sports. So as you can see here, Stuart Broad, having more than 500 wickets, and he has asthma. But as far as you, if you look after your asthma, it should not limit you from exercise. If a child gets an asthma attack, what to do? Help them to sit up straight and keep calm. Keep calm is really, really important. And when we see these children in emergency department having an asthma attack, we talk to the child, we talk to the parent, we try to keep them reassured. And same thing at home as well. Have them take 1 puff of the reliever, which is your, blue inhaler, generally every 30 to 60 seconds for up to 10 puffs. Call 999 for an ambulance if they don't feel better or their symptoms are worse. And repeat step 2 if the ambulance takes longer than 15 minutes. Just to mention a few other treatments, like, if the child also has nasal symptoms particularly, or, other skin allergies, we use antihistamines or anti-allergic medications. I call it a united airway. So your nose and pharynx is all connected to your trachea and your airway. So if your allergic symptoms of nose are not treated well, and child is having postnasal drip, their asthma control is usually not fantastic. Flu vaccination, we advise to children, particularly at risk of asthma. If they have asthma, flu, or other viral illness, it just makes their asthma exacerbation worse. Antibiotics are rarely used in asthma, but our moderate to severe asthmatics, if they have lots of secretions, and if things are not improving, sometimes we use antibiotic. But in general, I think for general public, it's really important to understand that, for common coughs and colds or mild asthma, antibiotic is not the solution. Antibiotic is for a bacterial infection, and should only be used after advice from your healthcare professional. Oral steroids, I mentioned earlier on, are key for the asthma exacerbation treatment, but aim is to not have the exacerbations. And with that, I thank you all for your attention, and open for any question. And this is my colleagues at Royal Manchester Children's Hospital keeping us going with the work with the children with asthma and other conditions. So open for any questions.
Thank you, Dr. Ghulam Mujtaba. Very, very nice presentation. We have few questions. One, I think you have already answered. We have a question that can children have flu jab when they are asthmatic? So I think you have already partly answered. If you can tell a bit more.
Yeah, thank you. Yeah, thanks for, it's really important question. And I think nowadays we suggest that, every child should get the flu vaccine. But if you have an underlying health condition like asthma, you're more prone to, getting these symptoms worse with the flu. So anything which you can prevent, so that's kind of another trigger. You're just making chance of having an asthma exacerbation, which will lead to, for example, hospitalization or steroids, is less. So anything you can do to actually reduce that risk is important, because children who end up in hospital, we have thankfully a smaller proportion, but I was on call like last week, for example. So we had two children in high dependency unit, for example, who were needing treatment for asthma. So it's not unusual. And the triggers are usually viruses. So for in flu, which is influenza, if we can actually prevent, fantastic. So yeah, I would suggest for them to have flu jab.
The other question is a bit longer, but what essentially asking is that initially this 5-year-old boy was diagnosed with croup and bronchiolitis and treated with steroid tablets, but now has been started on clinal inhalers. So they are asking how they be sure that this is asthma, and whenever he's got the cold, he start having a cough, chesty cough.
Thank you. That's really, really good question. And I think that's a typical referral I get in hospital, and that's the most of the children who come to us. So I think it's really important to go through the history again, looking at triggers, and this is the sort of patient you would have to say. Clenil is inhaled steroid, and it's a preventer. So what is really important, one of the important tests for asthma is response to treatment. So if you have asthma, as you can have seen in my talk, and I have some kind of models as well. I don't know whether you can see here. This is like a normal airway, if you can see my picture. Should I stop sharing my screen so that I can show you this?
Yeah, you can do that, yes.
Okay, I'll stop sharing. And so you can see here, this is a model I show it to the patients and parents. This is an airway where there's thick kind of mucus inside, and the mucosa is tight. So with these children, I mean, if the inhaled steroids are started, you should see an improvement. And if there is no improvement after 6 weeks, you should then look at, is this asthma or is this something else? Or if this is asthma, maybe we are not doing something right. Maybe we are not actually using the inhaler right. Is the technique right? Have a look at Asthma UK website, talk to your pharmacist, talk to your GP, talk to your asthma nurse, and bring your device with you, and show it to them, how your child uses, and also important that you change the device every kind of 6 months to 12 months. So I would suggest this child, again, going through the basics, and it's really important we go through that algorithm to get it right. And if this child is now 5, can probably try some lung function like spirometry as well, and check. So if you're not sure, then you have to kind of do the next level of investigations, which is looking for spirometry, making sure that is there any obstruction, doing pheno. Pheno is the other test we use. And if the value is high, so putting all this together, then, I mean, in my clinic, almost kind of more than 90%, I get, either this is asthma or not. When they come to us, the question is kind of like 50-50. We've tried this treatment, we are not sure. So we go through this algorithm of investigation, and we don't stop. We continue until we find out and figure out. So yes, the problem is in asthma, there is no one standard gold standard test. Like, if you go with a heart attack, maybe you do one blood test and you will know. But with asthma, it's everything together. You have to combine, but then you get to bottom that this is asthma or not. So what I would suggest to this family, that if the child is responding to Clenil and symptoms are improving, then persist with that, and and look at whether child needs another treatment added. But if not, then you can ask referral to a pediatric respiratory department, and we can look at that. We can, do other tests, and we can try to identify the triggers as well, because some triggers you know from the history, some triggers you might have to do the blood test to find out.
The other question is about the triggers. Can fruits trigger the asthma?
That is an interesting one, and I think a difficult one to figure out. So in my experience, it's not a common one. It's not a common trigger, but rarely we have seen some children. And if we have children specifically with this sort of triggers, then we are usually looking at sending them to our immunologist to kind of specifically look for those. So it's not common, but it can happen. Quite rare though.
We have another question, which is essentially about the prognosis, that if child get asthma, will it remain for a life, or can condition be reversed, or can child be grew out from asthma?
Thank you. That's again really good question, and a lot of younger children, when we see if they have mild symptoms and they are requiring low dose treatment for asthma, more than half of them actually, as they're growing, they come out of treatment. We do a regular review of these children, and asthma settles down. Now, if it's a genetic predisposition and a family history, obviously genes cannot be modified, but your symptoms settle down. So sometimes you have asthma, but you actually don't have symptoms, and everything settles down. You have a fantastic control of what we do is we review them regularly for, if a year and they had good control, no asthma exacerbation, we reduce the treatment and then review again in a year, and sometimes we stop it. And we see, I've had many children actually discharged from my clinic, and similar experience with the general practice as well. These patients get better. So yes, asthma is particularly presented in younger children, which is more a borderline viral induced wheeze type picture that settles down. Children with severe asthma, moderate to severe asthma, would need to have treatment lifelong. But again, coming back to, if you look after your asthma, you can manage the symptoms well. You can have a fantastic quality of life if you actually look after your asthma.
Yes, we have the similar experience with atopic asthma, which the children, if they have severity from the beginning, usually it stays for the life. But if they are mild and gradually settling down, they usually grew out by the age of 10. So I think probably same thing applies to the other things which is a part of atopy, like asthma and hay fever. So that goes along. So is there anyone else have any questions? Looking on, so not any more questions. I think we covered quite extensively. Most of the topic you already covered nicely. So I think maybe not any questions. I don't know, Dr. Shahid has any questions? Or so if there are no questions, so we will thank you. Oh, Dr. Shahid is coming. Yes, go ahead.
I just say it's a wonderful talk, and I always enjoy listening to Dr. Mujtaba. Do you think asthma is a risk factor? I mean, I'm not talking about childhood asthma. Is it a risk factor for bronchogenic carcinoma in the long term? Like we listen about COPD and the risks of bronchogenic carcinoma.
Thank you. I think thanks for an interesting question. I suppose I think I try to keep my talk kind of more simple, not going into too much detail of the more advanced treatments like biologics, for example, omalizumab and those things we use, mepolizumab, and I have a lot of talks for the healthcare professionals separately, for the general practice and for nurses and for the other professionals. In terms of the bronchogenic carcinoma, as far as I am aware, thankfully, That's not the risk factor, particularly in pediatric population. But as far as I'm aware from literature, I don't think it's a risk for adult asthma leading to the carcinoma as well. But theoretically, yes, you're probably right. I don't know, if you have a chronic inflammation in the airway, which is kind of looking at a very severe asthma, whether there is any association. As far as I'm aware, no one has proven it, but it is probably possible.
One last question before I think the other, I think some parents have not asked here, but when I come in my clinic practice for atopic eczema, one of the questions is, if you're using these steroid inhalers or steroid treatment topically, would they retard the child growth, or would they have any impact on their growth? So this is a common question asked in my clinic as well. So I suppose maybe relevant to your ones.
Yeah, it's commonly asked, and our answer from the evidence is, and Andy Bush from Brompton, actually, he's kind of, you can understand, like a expert in childhood asthma and respiratory conditions, and he had done a review not long ago, and the conclusion was that inhaled steroids treatment, the doses we use, don't lead to reduction in height in children. And he actually put it very nicely that your risk of your child dying from moderate to severe asthma is higher than, if a child is eventually 2 centimeters short, for example. So really, I think it's really important. It's really important that, you get this right, that inhaled medications do not restrict your eventual height of the child. Your child will be restricted by other quality of life, not able to play, exercise, missing school because of asthma exacerbations and other factors. So it does not reduce the final height.
Okay, so I think if no more questions, so we will finish this today's talk, and we are really very grateful for Dr. Ghulam Mujtaba to give his time and prepare all this work for today's presentation. So I thank you, everybody, and we say Allah Hafiz and Assalamu alaikum.
Wa alaikum salam, and thank you very much again, Dr. Tariq.
Thank you.